What a great introduction. So much to be proud of. Really so impressive. So yeah, my name is Sarah Hales. I might know some of you in the audience. I'm a psychiatrist at the Princess Margaret, and I am in sort of a unique position as a mental health care provider. It's very unlike the work that happens in other mental health clinics. I tend to see people who don't have a lot of psychiatric illness. I don't tend to treat a lot of people who have schizophrenia and bipolar disorder or depression. I see a lot of people who are coping with the crisis of illness and who are healthy psychologically but are incredibly distressed by that experience. So I spend a great majority of my time actually reassuring my patients that they are normal, that they don't have a psychiatric issue, but what they're going through is real, it's significant, it's distressing, and that they're going to feel better over time. That's a big part of the work that I do. I think that we live in a society that is actually pretty uncomfortable, particularly with negative emotion. I think we live in a culture that wants people to think positively all the time, to be happy most of the time, and doesn't have a lot of patience for anxiety, for sadness, for anger. And we want people to dismiss that, push that under the rug. And I am a big believer in the importance of emotion, and that emotion actually is a healthy and normal part of us. So I'm going to spend the majority of my session talking about that, talking about what is normal in the context of a serious illness for patients and families, and how we might cope with that. So back to what is normal in terms of emotion. Anxiety is a really common experience, and Annette talked a lot about that, with her diagnoses, this experience of I'm alone in it, I'm worried, how am I going to manage? And when you think about anxiety, can be very problematic, but it also is very healthy. I mean, when you think about fight or flight, that response that all of us have in the face of a crisis, it's a healthy response. It activates us. We attend to what's important. We start dealing with the crisis that's in front of us. It's motivating, and it can be very beneficial. And with those negative emotions also, we get to experience positive emotions, right? We get to experience love and the excitement and happiness of connection. And I think it all is of a piece. It all goes together. You kind of can't have one without the other. And emotions are normal. They can be beneficial to us, and usually what happens is emotions come and then they recede. That's the normal experience of emotion. It doesn't usually stick with us for long. They're transient. They fluctuate over time, and that's sort of what's healthy and normal in terms of psychological adaptation. Emotions become problematic, of course, when they are negative and prolonged and persistent and start to affect our functioning. So I'm going to talk a little bit later about what to monitor for in terms of what's problematic. But I really, again, want to emphasize that a lot of distress at transition points, at diagnosis, as you move through treatment at different stages of disease crises, and a lot of heightened distress associated with that is normal. So everyone with cancer experiences some distress, and don't let anyone tell you otherwise. There is no one who finds out that they have a cancer diagnosis or they have a loved one who has cancer who doesn't experience some distress. Often there's anxiety and panic. There can be a lot of anger and frustration. There can be a lot of sadness, but that is normal. And we talk now in healthcare about psychological distress as the sixth vital sign. And a lot of you, if you have treatment at UHN or at other hospitals, you'll be screened not only for how you're feeling physically on clinic visits, but also how you're doing emotionally. And we're trying to encourage attention to the psychological aspect of cancer, which is a normal part of it that we need to be aware of and be targeting support to. 30%, of course, of melanoma patients and 20 to 30% of their caregivers will report clinical levels of psychological distress at some point during the treatment experience. And that's pretty much the same across cancers. So melanoma is no different than any other type of cancer. We see the same sort of ratios. It's about a third of people at some point will have problematic emotional distress, but everyone is experiencing some distress at some time. On the right here, this is the distress thermometer. This was developed in Sloan Kettering, and this is what is used in some clinics in order to get people very quickly to rate how they feel in terms of emotional distress at a given point in time. But again, emotions are like waves. They may come, they crash over us, they may be quite intense and very distressing, and they often then will recede over time. There's a lot of different sources of distress, so no one experience is the same as anybody else's. Don't let anyone tell you that you need to be experiencing certain things in a certain order. Everyone is different and unique in terms of how the cancer experience hits them. It depends on your individual psychology. It depends on the kind of crisis you've had to deal with in the past. A lot of cancer experiences, there's a lot of overlap regardless of the kind of cancer, but if you look at the research for melanoma patients, particularly qualitative research where they interview patients and family members and then try to generate what the themes are of what sources of distress, you see these kinds of things mentioned. You see patients and family members talking about the shock of diagnosis, talking certainly about the fear of spread of disease or recurrence, talking a lot about scarring and disfigurement. So melanoma is in many cases a cancer where it's visible and the treatment effects are visible, and so people are having to deal with something that's not hidden to other people, and they have to then deal with the reactions of others in terms of their disease and treatment. The discomfort and complications of surgery, feelings of guilt and responsibility for diagnosis, again, not uncommon across the board in terms of different types of cancers, but I think particularly for melanoma and skin cancers where there is an association with sun exposure and people often feel they are somehow responsible for their illness. A sense of injustice, the why me, what we call the existential questioning, why is this happening to me, why do I have to go through this, how can I explain the suffering that I'm experiencing? And again, for many people, regardless of stage of disease, a heightened awareness of mortality. So it's not just people with advanced disease who get a cancer diagnosis and think about end of life. And that's, again, a source of crisis and anxiety and distress for a lot of people. So there's many tributaries to an ultimate pathway that leads to significant distress. But again, back to the idea of these waves coming, crashing, and then receding, what we know is that distress fluctuates and tends to get better over time. And this is a graph that we see no matter the kind of cancer. This is for melanoma, but any other cancer, we see the same thing. We see right around the time of diagnosis, there's a lot of distress and anxiety, and then that gradually recedes over time back to baseline as people get an understanding of what lies ahead. They have some sense of the treatment plan, and naturally we're adaptive and more resilient than we imagine, and that distress level often will go down. And then we just see other fluctuations over important transition points during the course of illness. So advancement of disease when people develop new symptoms or complications of treatment, at the end of treatment, so again losing the support of regular care and monitoring, people will often have an uptick in distress, but again most of those upticks then over time will resolve. And so again, I'm spending a lot of time in my clinic often and reassuring people that things will get better and they'll often feel better over time. There's also a lot of difference depending on the phase of care. And again, some of this qualitative research on melanoma has looked at this, looked at the different stages, diagnosis, treatment, what we call survivorship phase, and the kinds of problems that people are really focusing on that are triggering their distress. And at that initial diagnosis phase, we hear people talk about often shock, panic, devastation, and for some people numbness, a sense of not feeling anything. In one of these qualitative research studies, a patient was quoted as saying it's very confusing. You're going from doctor to doctor, they're saying things at you, and you're just sitting there going, I've got cancer, and you're definitely not taking anything in. So that process of coming to terms with what's happening, understanding the information and facing reality takes some time, and managing that initial terror and coping with that uncertainty to be able to go forward and make treatment decisions is an initial very difficult stage for a lot of people. And again, that's a period where we see that heightened level of distress that we know will go down as people get into treatment and often feel more stable. But then the treatment phase has its own challenges. Certainly treatment decision-making is a big one. You know, we live in an era where patients are considered consumers and people are given a lot of choice, and that's a great thing. But for some people, it's a really anxiety-provoking thing. We don't have a system as much where doctors are telling people this is what to do, but they're giving them options. Certainly at our hospital where we have clinical trials, it's another decision people have to make and weigh the risks and benefits and sift through the information they're being given. And so that can be a source of a lot of distress and worry for patients and families. Difficulty working with the treating team, not Dr. Butler, but it's a very intense relationship when you have a serious diagnosis and you're very dependent on your nursing staff and your physicians and the people looking after you. And with that intense relationship can come a lot of frustration, can come a lot of disappointment if there are errors made or things fall through the cracks, and it's a very difficult and intense relationship. There could be communication issues, and so that's often a source of difficulty for patients and families. There's the treatment and its potential complications, so pain, physical limitations, lymphedema, which Annette talked about, are all difficult, and those things can trigger emotional distress. It's very difficult to feel upbeat, positive, and happy if you're experiencing even one physical symptom, let alone 2 or more. And then financial stressors, that should have an extra S there. But that's, I think, really significant. A lot of this research where financial stressors is highlighted is American research, and we think in Canada we have a universal healthcare system, but as Annette was pointing to, you know, that certainly not all drugs are covered, but also even if they are, we really don't acknowledge the financial cost and burden of significant illness. When someone can no longer work, when their partner or caregiver isn't able to work, when you're questioning your ability to continue to put money away for future savings and retirement. So it's a huge financial stressor, the cancer experience, that I think we don't give enough attention to in Canada. And then there's survivorship. So for those people who finish treatment and then are told, all right, we're going to see you in 3 to 6 months. For many people, this is liberating, but for some, that is a time of really feeling abandoned and adrift. You know, you had a lot of support, a lot of people checking in with you, and now suddenly you're not seeing people as frequently. And interestingly, that's when a lot of patients are referred to see me. And it's because they were expecting to feel better. Treatment is done. I should feel good, and I don't. And some of it is often that anxiety around not having the same amount of supports. Certainly there's fear of recurrence. Again, in this qualitative research, one patient was quoting, it doesn't matter how far away from the diagnosis stage, you never really feel like you're in the clear. And living with fear of recurrence is something that people have to come to terms with, and again, never really goes away for individuals. Once you've had any cancer diagnosis, people are often more vigilant, monitoring, worried about the possibility of recurrence. There's often continued physical limitations and treatment effects. So again, people are often really anticipating I'm going to be done treatment and things are going to be great, but they may be left with pain, disability, disfigurement, lymphedema, and that is something they need to come to terms with. And then there's just the difficulty of shifting the focus to the future. So you've been very consumed with the job of managing cancer, and now you have to begin to get back to life and look to the future, and that can be a source of distress for many individuals. And then there's the challenges of metastatic disease. And, you know, this is an area that, I mean, I see patients at all stages of disease, but I have a particular interest in advanced and metastatic disease. And again, I think as Annette was highlighting, this is one of the amazing things that I've seen in my career, people living longer and longer with advanced disease. So people who have metastatic melanoma, but are living for a long time in this place of uncertainty. They're still working, they're still able to engage in life, but they're living living with this sense that the illnesses are not curable, and they have to find a way to live while they're aware of that uncertain future. And so they're facing all of the other issues that I highlighted, but now also this heightened sense of fear around mortality, and trying to find this balance, right, to be able to live while you have this awareness you have an illness that might end your life. And so I think that's a particular challenge that can be stressful for people. Interestingly, you would think that people with more advanced disease would all have higher distress. That's not always the case. Again, back to that idea of fluctuating and transient distress. You know, some research shows that people at this stage of disease have higher distress. A lot shows they don't. But this transition to metastatic disease, or when they have a lot more symptom burden, they may have more distress. And then caregivers. So I wanted to make a special note of caregivers as well. Again, I have an interest in supporting families as well as patients. And they are, I think, the invisible ones often in the course of cancer treatment. They have all of the same concerns that patients do, plus trying to manage everything else in life. As one caregiver was quoted, "You're the breadwinner, the domestic manager, the guy writing the press releases, and the moral support for your wife and your wider family." So this idea that it's caregivers that are keeping everything running. They're often helping a patient navigate the healthcare system, attend appointments. They're providing emotional support for the patient extended family, and they're also trying to fill in the gaps of managing the multiple roles that patients might not be able to fill when they are not well. And caregivers often don't feel entitled to have that distress. So patients get a lot of care. They get a lot of people asking them how they're doing. They're the designated unit of care. But I think caregivers often feel they shouldn't have distress. As one caregiver was quoted, "There's no one you can talk to, because as soon as you go, oh yeah, he's got cancer and I'm in a terrible state," they think it's not about you, it's about the person with the cancer, which is the truth. So there's this sense that, yeah, that is true, that my loved one is the one that's really going through this, and yet it's having a huge impact on me, and I don't feel licensed to ask for help or talk about it. I think I'm depressing you. I think people, as I'm talking, the crowd is getting like heavier and heavier. But the good news is that, again, we cope, right? This is the amazing thing that I see every day in the work that I do, is how resilient and strong people are. They often don't imagine they'll be able to cope with cancer with the initial diagnosis, and then they find themselves managing. And people will come to my office and say, "I need tips. Like, you got to tell me how to do it. How do I cope?" And I'm frustrating them all the time by saying, there's no just one right way to do this. It depends on who you are, and everybody is different. And so I'm going to list a bunch of things that people talk about, and some of them are contradictory to one another. And it really depends on the kind of person that you are and what you want to make use of and what's working for you at a particular time. And that's really my mantra, is not that there's one way to cope that's good, but you need to do what's working for you while it's working. And that's what to monitor for, is the way I'm choosing to deal with this, is it working for me now? And if not, to change course. So for some people, it's leaning on informal supports, and that's a huge one for us. We're relational creatures, right? We talk to friends, we lean on family. But it's not for everyone. And I'll have some family members say, "Look, my husband, he really needs to talk to you. He needs to see a psychiatrist. And the last thing he wants to do is talk about his feelings. That's not the way he's built. That's not what he's comfortable with." And so it depends if that's your go-to source of support, then that's worthwhile. Active problem solving. So some people need to take control. They need to get information. They need to be on the internet. They want to know everything about the clinical trials. And for them, that really reduces anxiety. That makes them feel good. Positive cognitive appraisal. So some people, I need to focus on what's good in life. Some people need to make what we call downgrade comparisons. I need to remember how life could be worse. I had a patient in my office today, actually, who was just telling me he feels so good today, strangely, after the horrible attacks on Yonge Street. And for him, this is a man who's living with advanced disease, and this was a wake-up call to him, how different my life could be and how there's so much for me to feel good about. And for him, that was hugely positive kind of comparison. Meaning making, we're meaning, making creatures. We're often trying to think about our situation, find a silver lining, find a reason, reevaluate what's important to us in the face of illness, and that's a very positive approach. And then for others, it's relinquishing control to the treatment team. I don't want to know. My doctors and nurses know best. They're going to tell me what to do. I'm not going to go on the internet or listen to anybody else. And that can be hugely reassuring. For some people, it's distraction, it's redirection, it's calming activities, or even what some people will call denial and not thinking about it. And that can be very beneficial. If it's meditation, if it's music, if it's exercise, not thinking about cancer, if that's working, can be beneficial for people. And then certainly religious practices and beliefs and things that, again, I think are calming and centering for people are often go-to in terms of coping with illness and the stressors. But again, the best approach is what's working for you while it's working. And if there's anything we know about what's healthy, it's being flexible. So when something is not working, being able to switch gears and do something else. I actually saw a patient, a young man in his 30s today, was malignant melanoma, and he has metastatic disease, and he was diagnosed, I think, in the fall, and right now he's just been given a reprieve where he only has to come to the hospital once every 3 weeks, and he's chosen in between coming to the hospital, he's not going to think about it, and he's trying to focus on being with his daughters and just ignore that he has cancer, and for him that is working, and I would never argue with that. And I know that my job is to try to be there for him if that stops working, and if he finds anxiety is growing, or if he's having to face it and make treatment decisions and that avoidance strategy is no longer effective. And so the other hat I'm wearing as a psychiatrist is trying to know when it's problematic in terms of the way people cope. And some people with cancer will develop actual mood and anxiety disorders. I remember I told you at the beginning, maybe 30% of patients at some point will have clinical levels of distress. It's about 15% will eventually have an actual diagnosis of a mood disorder like depression or an anxiety disorder. And what's really important for you to monitor for is distress that's prolonged, that's persistent, that's affecting functioning or your ability to engage in cancer treatment. So that's when you need to be looking for more help. You need to talk to a nurse, your family doctor, your oncologist to have more assessment and perhaps treatment. So that's really what I'm also monitoring for as a psychiatrist. When is this bordering on problematic in terms of distress? Not just the waves that come and go, not the up and down course, but when it's really persistent for weeks on end and you're not able to enjoy life, you're not able to engage in treatment or function in the way that you need to. But I just want to make another pitch for this idea of resilience and give you some of the positive news. You know, I'm a researcher, and one of the things that we talk about in psychology is this concept of response shift. I don't know whether people are familiar with this, but again, I think it speaks to our resilience. If I had a group of people who are in here who did not have a melanoma diagnosis, and I asked them to rate their quality of life, and they gave me a number, and I came up with that average of all of their ratings. And then I asked those of you in here who have melanoma to rate your quality of life, and I got an average. And we compared those. Interestingly, the research would show us that the melanoma group, that your quality of life, you'd rate it the same as or even higher than those people who don't have melanoma. And that's on average, and that's not at those times of crisis. But it speaks to the fact that we're resilient and that people are often able to cope with things they don't imagine that they'll be able to. And I see that all the time in my practice, that people are able to find meaning in life, to find purpose, to feel good, have happiness, even when they're living with something they can't imagine living with at first diagnosis. So that's response shift. And that's this idea of after a forest fire, there can be rejuvenation, even growth. And the idea of even a higher quality of life is this other potential benefit finding. So I'm not going to tell you cancer is a good thing and I'm going to be thankful for having it. But some people do find there's this benefit finding, what we call post-traumatic growth that comes out of the experience of a serious illness. I just want to talk briefly also about the tyranny of positivity. Jimmy Holland, who was the grandmother of psychosocial oncology, is my field at Sloan Kettering. She coined this term, and I see this all the time in my practice. For many people, I talked about positive cognitive appraisal being a way to cope, and for many people it is. Thinking positively is helpful, and they find this really works for them, but I find for other patients it's really, they feel it as an additional burden. It's something that leaves them feeling more alone and sometimes guilty that they're not able to think positively, and even worried that if they're not able to think positively, their cancer will progress unnecessarily. And I really see this as a problem, again, as I spoke at the beginning, in a way a cultural problem. I think we have difficulty with negative emotion. And it's actually a myth, that negative emotion can trigger, worsen, or cause cancer. And again, I'm talking about the feelings that come on like a wave and then pass. Those negative feelings are normal and human. When you think about it, they're even pre-conscious sometimes. Sometimes you'll have a feeling that overcomes you, and only after you start to feel it are you able to name it. Oh, I'm anxious, or oh, I'm feeling really angry. Feelings come often even before we have a chance to name them and know what they are. And that's normal, and for many people, not giving them license to name those feelings, to express it, can really cause them to feel more alone and isolated. So I'm often trying to encourage people to be able to speak their negative feelings. The sustained, persistent, prolonged negative feeling that is affecting your functioning, that's not okay, and I want to do something about that. But intense, strong negative feelings that come and go are normal. And I just wanted to say something just before I finish up about this idea of us all being individuals and have different ways of coping, how the cancer experience is different for every individual. This is a word cloud that was generated by a researcher in the United Kingdom, and her area, she's interested in the way people cope with cancer and the way they talk about cancers. And this is a word cloud generated from a lot of self-help literature about cancer. And it's really fascinating, I think, if you look at these words, because you see these themes, and the two that are really most prominent here are the idea of cancer as a battle, something you're going to fight, you're going to win or lose. And that's, I think, a metaphor we often hear people using when it comes to cancer. And the other is the idea of a journey or a path, something you might need guidance or have to help navigate. And she was just talking about this idea of metaphor, and that everyone has metaphors that speak to them and some do not. And I think that's a huge part of the work that I'm trying to do with my patients, is trying to understand as individuals and as families, what are the metaphors that work for you, that are helpful and beneficial, that help you understand yourself, to feel heard and feel supported, but not to be prescriptive and tell people this is the way you need to look at your cancer. And if there's one message I really want to transmit, it's that idea, to think about who you are as a person, what kind of support you need, to think about your loved one and who they are as an individual, what kind of support they need, and be able to fine-tune it rather than have a one-size-fits-all approach. Again, I've seen a lot of melanoma patients in the last week. It must have been in preparation for coming here. But I saw a patient today who is so interesting to me. I saw her with her daughter, a woman in her 70s, who again has metastatic disease. And she was telling me that this is an anxious woman who's had a lot of trauma in her life, and often, a big roller coaster, often ups and downs. And she said to me, I have two daughters. I have one daughter, the daughter who is sitting with us, who knows a lot about relaxation and meditation. And then she said, I go to her and she helps distract me and calm me, and that's hugely beneficial. But I have another daughter, and she's the only one I can talk to about how I feel when I'm feeling sad or angry. And she said, sometimes I just need to say it. I don't want someone to make it better. I don't want them to fix the problem. I just need to say the words. And to me, it was such a beautiful story about somebody who has acknowledged that they have different needs at different times, and the importance of attunement, the importance of having caregivers who are able to try to give us what we needed at a particular time. Sometimes we don't always get it right? We say the wrong thing, and if you're a cancer patient or a loved one of a cancer patient, people often say the wrong thing. But the idea that we're going to try to correct that we're going to try to get it right, to allow people to feel supported, because if we aren't able to cure the illness, I think what we really can try to do is understand the experience and support people through it, and that's really what I have an interest in trying to do in my work. So sources of formal support, in addition, of course, to the Melanoma Network of Canada, there's a lot of specialized psychosocial oncology supports in different hospitals. We have ours at the UHN, Wellspring and Gilda's, of course, many of you be aware of. For people that like online supports, Cancer Chat Canada, there's After Cancer online course at University of Regina. And for people who have more advanced disease or have issues related to end of life, Canadian Virtual Hospice online has a lot of supports and information for patients and families. And there are, I'm sure, many more, but these are ones I'm often referring my patients to.